Hello, everyone. Today we have a case of a 45-year-old male patient with a history of membranous nephropathy who came in to the clinic for a follow-up visit after he received rituximab for 2 doses. Um, he had antiphospholipase A2 receptor antibody positive both in the serum and positive stain in the tissue biopsy. Um, his visit was 4 months after he completed 2 doses of 1 gram rituximab with some improvement in the lower extremity edema. Now he is on enalapril, metoprolol, furosemide, and also he was receiving corticosteroid, but this was stopped, and he is on aspirin. His blood pressure is 122 over 72. The rest of physical examination were benign. Laboratory study uh, will show it in the next slide that has been drawn 2 months and 4 months after the kidney biopsy. And as you can see here, this is the biopsy time. His white count was 7,000, creatinine 1.1, GFR was above 60. His albumin at time of biopsy was 2.8, with high antiphospholipase A2 receptor antibody and 7 gram of protein. 2 months and 4 months, this is a follow-up lab. White count stays stable. Of course, went down a little bit. Creatinine is almost the same. GFR is stable. Albumin has improved a little. And the antiphospholipase A2 receptor antibody is now less than 14, and the positive level is above 20. His proteinuria, though, still 5,000 milligram a day, so went down just a little from 7 gram to 6 gram. Now it's 5 gram. And the question is, which of the following should you do now? Would you continue the antiproteinuric measures only without giving any immunosuppressive? Or would you redose rituximab or switch to steroid and cyclophosphamide or switch to steroids and calcineurin inhibitor or switch to steroids and MMF? Again, this is a case of membranous nephropathy, idiopathic, with improvement of the antiphospholipase A2 antibody level, but the proteinuria still persistent, 5 gram from 7 at presentation. And the correct answer here is just to continue the antiproteinuric measures. The patient doesn't need any further immunosuppressive medications at this time, because the take-home message is the importance of antiplatelet antibody in membranous nephropathy and the serial assessment of the level. If it's going down, this means that the patient is achieving immunological remission, and immunological remission is usually precedes the clinical remission up to 1 to 2 years. And immunological remission is defined as depletion of the antiplatelet antibody or evidence that the antiplatelet antibody titer is below the cutoff positive limit. If this happens, this means that the patient will achieve clinical remission, but it's just a matter of time. So be patient and wait. Don't redose rituximab. Don't give cyclophosphamide or cyclosporin, because the patient is already in immunological remission. Again, it might take a year or two, up to a year or two, for clinical remission to happen. So serial measurement of antiphospholipase antibody as non-invasive biomarkers is very important nowadays in membranous nephropathy. Um, for years, we were looking for non-invasive good biomarkers that can correlate with the activity and the severity of the disease. And now we have one So we don't only depend on the degree of proteinuria or the serum albumin or other clinical manifestation, but also we depend on the antiplatelet antibody. There is no need to add any immunosuppressive medications, just to follow the antiplatelet antibody and keep the patient on antiproteinuric measures for now. Here are the references if you would like to go and read the article. This is Lawrence Beck article. This guy is one of the founder of the antiplatelet antibody. Vervenza, of course, from Mayo Clinic, he was the principal investigator for the mentor trial. Both are very well known. Of course, everyone knows Galasov, and of these investigators are very well known in the field. Please enjoy reading this article and have a good rest of your day.